Good day. I am Sherilyn Francis with the Georgia Health Information Technology Extension Center. The future of health IT is here. Turn it on. We encourage you to connect with Georgia High Tech at www.ga-hightech.org, and you can tweet us at Georgia High Tech. Georgia High Tech is the only federal and state endorsed expert to assist providers in the achievement of meaningful use of EHR technology. Georgia High Tech is located at the Morehouse School of Medicine, National Center for Primary Care. And now a few housekeeping measures. As participants, microphones are muted and shall remain muted through the duration of the presentation. We ask that you check your internet connection by locating the icon which is displayed on the slide at the upper right corner of your screen. If you have a less than optimal internet connection, you may experience audio and/or video delays. Additionally, we encourage you to refer all tech questions or tech issues to the Tech Support Chat Pod, and we ask that you refer all questions for our presenters to the Presenter Q&A Pod. There will be periodic stopping points for question and answer, and there will be time designated at the conclusion of the webinar for question and answer. I now present to you today's webinar entitled Audit Preparedness. Are you ready in case of an merit-based incentive payment meaningful use audit, presented by Jeff Roboleski, Manager, Myers and Stauffer, and Melanie Ferris, Manager, Myers and Stauffer. In compliance with ACCME guidelines, the following speakers have financial or other relationships with the manufacturer of any commercial service discussed in this educational activity. And now the objectives for today's webinar. To understand the goals of audits related to AIU and/or meaningful use attestation. To learn the latest updates of the required attestation documentation. To hear helpful tips for managing a successful audit, and to identify the requirements for security risk analysis. And now, Jeff Roboleski.
Hey, thank you. It looks like some people can't hear. They're not getting the sound. Is that correct?
Thank you, Jeff. Brian is working on that on the back end.
Okay. All right. Well, thank you for coming out and joining us today. My name is Jeff Roboleski from Myers and Stauffer, and we'll go over being prepared for a post-payment audit should you be randomly selected. And before we go any further, the word audit typically causes a lot of anxiety, stress, fear, and we just want to let you know you can stay calm and we'll carry on auditing. And, what we mean by this is that, if you work with us, we work with you. We're not here to make this any more difficult than need be. This is not like getting audited by the IRS. We try to help and make this as pleasant of an experience as it can possibly be. Just a little bit about who we are at Myers and Stauffer. We are a CPA firm, and we specialize in government clients. We have 18 offices that provide services to 47 states. We are contracted by the Department of Community Health to conduct post-payment audit services related to Medicaid EHR incentive payments. So what is the goal of these post-payment audits? The goal is to ensure compliance with the federal regulations. Our goal is not to recoup incentive payments from you, the providers. And hopefully after we go through some pointers today, none of you will have to go through an unpleasant audit experience or have a recoupment. Just to kind of go over a high-level overview of our post-payment process, you will be notified of an audit via notification letter. Those letters will be mailed to you. And a couple of days after we mail the letters, we follow up with a phone call as well as an email to ensure that you receive the hard copy snail mail. In the letter, it's very general, it's very high level. It doesn't give specifics because we understand each and every provider's situation is different, so we just kind of are asking the who, what, where, when, and how. Typically during the phone call, if you have any specific questions, we can go over them at that time. Also at that time, we'll go ahead and discuss setting up a secure FTP account with us. It's an account that we create free. There's no charge, so that PHI can be transmitted securely from you to us, and in the event we sample your data, we can upload the data back to you securely through the FTP account. Once we do receive your documentation, we may have to make additional requests. You know, we don't know what we're going to get until we see it, so there may be some back and forth. We do try to minimize the contact via phone or email as much as possible. We do understand you're busy and you guys have other job responsibilities besides just dealing with us doing an audit. At the end of the audit, we will go ahead and let you know the results of our audit findings via a findings letter. The letter will simply let you know whether you passed or fail the audit. Should you fail the audit, the findings letter will have language included that lets you know you have the right to appeal our findings and what the process would involve. The post-payment process also, we have two different types of audits. We like to mainly do desk reviews, which that way we're not in your practice. We'll notify you, we'll get the documentation, we'll conduct all our work here at our office. That way, you know, we're not in your workspace. Should we have to do an on-site audit though, we do come out to your office. We schedule a time and a day that's of your choosing when we can arrive, look at the documentation. On-sites, we typically do conduct interviews. They're a little more in-depth and more involved than a desk review would be, so we do encourage everybody to kind of stay on the track of doing a desk review. We don't want to have to come out and interfere with your day-to-day business operations, and you probably don't want us sitting in your business, taking up space and taking up additional time than need be. Typically, though, lately we do try to steer clear of any on-site reviews. Oh, yeah. Do we want to go ahead and do the poll question at this time?
Yes, we do have our first poll question, and the poll question is, at what stage of the incentive program have you completed at this point? Additionally, we would like to make one correction to the title. The MIP stands for Medicaid Incentive Program.
So it looks like at this point a lot of the people on right now are in the meaningful use stage. So you've gone through the first payment and on to your second and beyond payment. So that's good. We have a lot of return providers. So in the post-payment process, some of you on here may have already been selected. I think I recognize a couple of names. Some of you probably have not. So some of this will cover eligibility as well as what we look at for meaningful use. As far as documenting your eligibility, the patient value requirement, you need to meet the 30% unless you're a pediatrician and you want to take the reduced payment of 20%. Also, if you're applying using group Proxy, we will have to verify that all patient encounters for all providers who are in your group have been included in that patient value. And the way that the Department of Community Health has defined group in the state of Georgia is everybody who's under that tax ID. Also, if you are a physician assistant or you're part of a group applying for a payment and you're a physician assistant, we will ask for evidence or documentation to make sure that the practice is led by a PA. And as far as what we mean by led by a PA, that could be a organizational chart. That could be something like from your time system that would show that the PA sees the majority of the patients at the practice. Also, if needy encounters are included in your numerator, we'll make sure that you're practicing at an FQHC or RHC. Nowadays, because we have access to claims data, we don't have to ask you for much on that side. We can verify that ourselves in the claims data. We will also verify for any application prior to 2015 that you're not a hospital-based provider. If we do flag you out that it appears that you're hospital-based, we will give you the opportunity to submit documentation to us to say that you're not hospital-based. We won't just say you're hospital-based and move on. We'll give you a chance to disprove that. And that we'll also check that the patient volume that's being calculated, that it was calculated using encounters. And we'll get to the definition of an encounter in a couple slides. So just high level as far as documentation that we ask for as far as for meaningful use for modified stage 2. We do ask that you submit system-generated reports. We also ask for screenshots that will support any yes-no measures. We will ask that any exclusion that you're taking, that we get either a vendor letter or that we get some sort of screenshot that would support you couldn't meet the measure. And the important thing about the screenshots to point out is that we can see the date and that the date it applies to the MU reporting period you've selected. Also, in addition to the meaningful use support, you also have to document your patient volume eligibility as well. In addition to this, we will ask for a copy of your security risk analysis, and we will check that the security risk analysis you've conducted and submitted to us hits all the points to meet the criteria set forth in the final rule. And also, if you have any questions as we're going through this, feel free to type them in. We can answer them as we go along. You don't have to wait till the end. So when you submit your documentation, how should it be submitted? For the patient volume, we do encourage that it come in an Excel file. It's the easiest form of data for us to manage and analyze. It usually cuts down on the back and forth, like questions we'll have for you, the provider, or additional things we'll have to request from you if you were to give us a PDF file. If you do submit PDF files, we would like to point out that you can't just print it off and send it to us in PDF. If you do that, we'll send it back and ask that you show us how you came up with your numerator and denominator and summarize that PDF data for us so that we can then analyze your PDF numbers. We can't compute your numbers for you because should we fail you or recommend recoupment, it would look like we computed the numbers rather than you coming up with the number. Like I mentioned previously, for your meaningful use, for the summary, it should come from your system. It shouldn't be handwritten. It shouldn't be something outside of your system that you're submitting. And like I said before, screenshots are a big thing. When in doubt, I would say go ahead and grab the screenshot. That way, down the line, if you got picked for audit, you have what you need to support your exclusion or your measure. And Melanie's going to go ahead and chime in on this one.
And I don't know if hopefully you can hear me. I was just going to say, for our experience dealing with meaningful use audits, that a lot of the challenges we've seen with providers is that you attest to the payment, you receive the payment, and then whoever has collected the information doesn't necessarily keep a copy of everything. And I want to stress that for meaningful use, grabbing the meaningful use summary report from your EHR software is something that is easiest if you do it at the time you're applying for the payment. It's very difficult to go back once you've been picked for an audit, years or a month down the line, and try to recreate the meaningful use summary report. So I would really want to stress that as you're gathering your information to attest for your meaningful use payment,
that you make sure you take screenshots and keep copies of all of your documentation, and in particularly the meaningful use summary report. So, sorry, I just wanted to chime in.
No, that's a good point. Thank you. And along with what you should be able to document, just some things that we would point out. They seem obvious, but based on experience, you should make sure that your screenshots, the summaries you submit, that they're legible, that we can read what you're sending us. If you scan it and email it to us, again, we should be able to see what you scan us. Sometimes there'll be smudges, there'll be lines in the middle of the page, and we can't see everything, so we can't complete our audit work. Another thing to point out is the data should be complete. You should be able to document and counter value for the eligibility period you select, so we should be able to see patient-level detail for the full 90-day period. It's not helpful if you're missing a month or 2 months. It's good if we can have the whole set of data and it has all the details we need to have, and we'll get into that later as well. Also, if you're applying using group proxy, it's important that the data you send us includes data for all the providers in the group, not just those providers who are getting an incentive payment or just those providers who are the eligible provider types. It should include everyone in the group. And it should be from the appropriate time period as well. To piggyback off what Melanie said, sometimes what we see is providers will attest for a certain period of time. We'll come back a year or two later for the audit, and you won't have the documentation for that time period. It's important that you keep your documentation for up to 6 years, so that when we come along and if you're randomly selected, you have that support available and ready for us to look at. So for patient value, details that should be included in the report that's sent to us, it should include the date of service. And again, the terms we're using, we understand it one way, and maybe in your report, another data field indicates date of service. Sometimes date of service in some systems is the claim date. So we're looking for the date of service. It's good if we can see the provider name in the fields. It's also good if we can get the patient's first and last name. If that's not feasible, it's also good if we can get a patient ID or a medical record number that is unique to that patient for that patient visit on that day. For those of you who have done AIU and you're coming in now for anything beyond 2013, you don't need to have the payment field anymore for the patient value. But for those of you who maybe are online, who we are maybe doing an audit or may get notified later this year for program year 2012, your data should include a payment field. That way we can see if Medicaid paid on the visit. And also it's good if we can see who the insurance type is or the payor for the patient visit. And again, back to the group proxy for patient value, to ensure that everybody is in the documentation who could see patients. We can accept payroll listings. We request timesheets sometimes to show that everybody's in there. Sometimes we just have to get like an employee roster listing where everybody's name from that eligibility period is listed and what their job titles were. That way we can verify everybody's in the documentation.
So there's a question from Natasha Davis, and it's asking about the preferred time period for the summary. Is it quarterly or more annually? And so I guess to respond to that, it would be for the 90-day period that you've selected for reporting patient volume. So if there's a quarter that is exactly 90 days, then you could use a quarterly report. But sometimes that's not always the case. So it would be based on the 90-day period for your eligibility period. That is what we would accept for the summary report.
And also along those lines, if it's for your meaningful use, you would want to generate the report, the summary. If you had to do a full year's reporting, you would want to run your report for an annual reporting period. Again, some of these things seem basic and just common sense, but you know, it's good to kind of just say it and get it out there, so please don't hesitate to ask. Documentation for the meaningful use for the stage 2. We do take the screenshots as we've kind of hammered in from your system, from the dashboard that summarizes your results. That displays the percentage-based measures. That way we can quickly see that, yes, you met all the percentage-based, you're above the minimum thresholds if applicable. If you took an exclusion, we can also see if you included documentation that supports taking that exclusion. And a key one here is for the yes objectives, the yes nos, to see if the functionality was enabled or disabled. If you have a system, a certified system, where you have the ability to enable and disable certain functionalities, it's good to take a screenshot from your meaningful use reporting period showing that you had the functionality enabled. I would like to stress that if you disable functionality in your system and then we come along post-payment and you can't show us that the functionality was enabled, more than likely we would have to recommend recoupment or a fail for the audit, because it's very hard for us to help you at that point to go back in time to show us that your system could have been enabled. So that's a key point there. Second one is a security risk analysis. Based on our experience, the security risk analysis for meaningful use audits is probably the #1 component that leads to failed audits. So it's very important that you seek out guidance from Georgia High Tech when you're conducting your security risk analysis. If you have any questions on the prepayment side before you get your payment, definitely ask Georgia High Tech, HPE if you need to, or even reach out to DCH. One of the things when we do our audits, when we notify people and we send out emails and we do the phone calls, a lot of times, not a lot, but it's not infrequent, we do get a little pushback as to who we are and why we're able to request the documentation we request. As part of under the HIPAA Privacy rule from the United States Department of Health and Human Services, states are required to have oversight activities paying out these federal funds. So they contract with us, Myers and Stauffer, to provide such oversight activities such as the post-payment audits. So, a lot of times people are fearful to give us their detailed documentation because there's PHI. We're covered under these rules. We have agreements with DCH. You don't have to worry about giving us PHI. You're not going to be in violation of any HIPAA rules. And again, to help you guys transmit data to us, that's why we offer to set up the FTP accounts free of charge, like I said. Just one thing about the FTP accounts I would like to point out. We can't give you your password to the account in an email. We do have to call and relay those FTP passwords to you via telephone. And that's a company policy.
And I was going to just chime in on that last slide. That part of doing the audit and what's covered under the audit is providing PHI or providing, and usually when we say PHI, we're really looking at ways to identify unique patients, because that's part of how you calculate encounters for patient volume. And so we have gotten a lot of questions about, well, we just want to give the Medicaid patient information to you, but we don't want to give you the non-Medicaid patient information since it's a Medicaid EHR incentive payment. And that is not okay. Part of it, the rule and the the privacy rule that we're allowed to audit under, and part of the state's rules as well, is that it has to be all documentation to support that you meet the requirements of the program. So that includes Medicaid information, but also the non-Medicaid patient information as well. So we've gotten lots of questions about that over the years, so just wanted to kind of clarify that it's Medicaid and non-Medicaid. So all of your patient encounters, if we needed patient level information, that is covered under this privacy rule.
Thank you, Melanie. So, okay, so what if you can't support an audit or you fail an audit? As I said earlier, we'll send you a findings letter. It's not like you're just going to get a notice in the mail from DCH saying you owe them money or they're taking your money back. We will mail a findings letter to you, and we will also email a copy of the findings letter to whoever we've been dealing with from your practice or provider at the group, so that you're aware of what we're recommending to the state. We would like to point out, before we finalize any of our work, we do submit it to DCH for their review as well as their approval of our findings. So like I said earlier, the findings letter, should you not agree with our findings, it will have language in there letting you, the provider or the contact, know how you can request an initial administrative review. The important thing about the initial administrative review is that you submit in writing that you would like to have this review within 30 days of the date of your findings letter. And that is 30 calendar days. It is not 30 business days. It is 30 calendar days. And this is a policy that, the folks over there at DCH have to follow because it's in the policy and procedures manual. Oh. Okay, so we do have a question asking what we would recommend for a provider who is unable to submit a new 90-day period for his or her patient volume because of lack of EHR technology being certified. That one's well, there's multiple ways to work with that. I'm just not sure if we should take it offline or answer that one online. The thing is, like we said earlier, we're not trying to recoup money, so we will work with you as much as possible.
And we'll work with you, and we'll have to definitely reach out to DCH if there's any specific provider question. So I'm not sure if we're able to answer this one right now, but just know that we would work with you and we would talk to DCH to get an understanding of the unique situation, and then have to follow whatever the program rules are and requirements to make sure that we're in compliance with the rules.
All right, so now some do's and don'ts to hopefully give you guys a heads up before you get paid, before we come along and audit you, to maybe make this a more pleasant experience, to get you more prepared. So the things you should do in order to have a positive audit experience. And yes, that sounds like an oxymoron, an audit and pleasant experience, but it's possible. The main thing is you maintain copies of all your documentation that support your encounter value. That would entail your Medicaid encounter value as well as your non-Medicaid encounter value. Some things to point out based on previous experience is you want to maintain access to all your records even if you change your certified technology vendors. A lot of times what we come across nowadays is it's been a couple years since you attested and got paid, so providers have maybe changed systems or changed vendors. So they don't have access to their old files. Should you be in this circumstance, we would encourage you that if you know you're going to change systems, that you maintain some access to those records, or definitely be sure to get a copy or backup of those records before you turn the system off or get rid of the system. Unfortunately, changing systems is not a good reason to not have the records for post-payment audit, unfortunately. Also, if you can't keep electronic access to the files, definitely then at the bare minimum, even though it's the least preferred method, keep hard copy of everything that you're attesting to in Mapper. That way, at the worst, you can always scan and email us your hard copies over, and we can look at those, and hopefully they work and meet all the requirements of the post-payment audit. It's also important that you do keep the dashboard summary or summary records from your meaningful use audit report that ties to what you attest to in Mapper. If we notice discrepancies between what we see in Mapper and what you give us post-payment, we're probably going to have follow-up questions, so it's definitely important to maintain that original documentation. Another do is, because of the concern over PHI and HIPAA these days, is that you transmit your documentation to our staff and our team securely. You don't have to use the FTP account we offer. If you don't use the FTP account, definitely be sure to do it securely when you do give us your documentation. We can accept documentation from secure encryption systems from you, the provider. I'll let you know, if we ever had to send PHI back to you, though, we cannot use your system. That's a company policy. We would then be forced to set up an FTP account with you so that we could transmit data securely back to you. But there are a lot of ways to securely send PHI. It's just the FTP account, in my experience with the provider community, it's just been the easiest. It's very user-friendly. And if you ever have trouble with it, we have support staff here in our office to help you with it. One of the other big things I would stress to have a good, positive audit experience would be communicate with whichever staff member you're working with. One of the worst things you can do is ignore the emails, ignore the phone calls, ignore the hard copy notification letter. That really puts us in a corner to where we can't do much if you don't give us much to work with. Our staff will definitely work with you if you work with us. We set deadlines. We understand you guys are working and have other day-to-day things to tend to. If you communicate to us what's going on, we can work with you, we can extend deadlines, we can change deadlines. But if you just kind of ignore us and don't respond and communicate with us, that really backs us into a corner, and nobody wins at that point. Oh, I'm sorry, we have, I forgot about the other polling question. So we do have another polling question, but it looks like nobody at this time needs further assistance with completing their attestation. So that's, okay, so there's a little bit of, and for those of you who are answering yes, that you do need assistance with the completion of your attestation, we would encourage you to reach out to Georgia High Tech, reach out to HPE. Unfortunately, because we we're contracted to do the post-payment, we can't provide too much guidance as far as prepayment, because then that would create a conflict of interest. If you do have a general question, though, we could try to answer that question today if you want to type it in. If not, though, I'm sure somebody who can help you will get back to you. And then all right. So also to help you with having a good audit experience, audit outcome for post-payment, knowing what we mean when we say encounter. The definition of an encounter from the state of Georgia, DCH, is it's any service rendered to an individual patient on any one day where Medicaid or Medicaid paid for all or part of the services. The thing with that definition is we are kind of in a catch-up phase for post-payment. So some of our audits are still related to 2012. We haven't gotten to a point where we're in 2013 and beyond, so payment does still apply for some of the audit work we're doing. Going forward, once we get out of 2012, though, the payment won't be as important. So for the new definition, once we get past 2012 and into 13 and beyond, it will include services rendered to Medicaid eligible. If they're just eligible Medicaid patient, you can include them in the numerator for your encounter value. Also, something that came up about a year ago, and the state modified its definition to help out the providers, is services rendered by students or those authorized to provide services directly, such as nurses, and supervised by the billing provider, can be included in the numerator. So if the provider maybe didn't see the patient, but services are being billed under that provider can include those services in their numerator. And also, to be considered Medicaid volume, the patient has to be Medicaid eligible on the date of service. For 2013 and beyond, as I've said, this will include zero paid and denied claims. It includes denied claims for those Medicaid beneficiaries where they've maxed out the service limit. The claim was denied because the services were not covered under the state's Medicaid program. Claims were paid at zero because another payer's payment exceeded the Medicaid payment amount, and claims that were denied because the claims were not submitted in a timely fashion. So again, for those of you who are still in the AIU phase, those of you who are in the MU phase, you're probably very familiar with this. The eligibility percentage, it's a fraction. The numerator is your Medicaid encounter value minus your CHIP over the denominator, which is all your encounters. And the CHIP nowadays, when you're filling out your calculator and you're doing your prepayment, you can just use the CHIP factor that's available on the calculator, and it will automatically take out the CHIP for you. We understand that identifying CHIP on the patient level can be very difficult for many of you. So the CHIP factor is there. It's built into the calculator. And it just takes it right out, and it makes it a lot easier on you guys when you're doing your MAPR application. Also, knowing the difference between group and individual proxy, it's important to know that you can apply as an individual, which means you'll just apply with your own encounter value, you the provider. If you use group proxy, that means you have to include everybody's encounter value for providers or for nurses who provide face-to-face services with the patient who all bill under the same tax ID. And it's important that we stress that anyone who's seeing patients rendering a service to a patient face-to-face and they're under the same tax ID, that's the encounter value for the group that you should be going for.
I was just going to chime in really fast about that. So for the tax ID and determining a group, this has been a challenge for some providers as well. And so it's important when you're completing the application to understand your organization's structure and knowing who falls under your specific practice's tax ID. We've seen some instances where for billing purposes, the organizations have set up multiple tax IDs related to the same facility, and so every clinic or facility is different. So being able to understand how your organization is set up and the tax ID structure of that and which providers fall under each tax ID or the one single tax ID is something that you each need to do your own research on and determine your structure so that you know who to include or who to exclude from each of the group group calculation that you would be doing to come up with your group's patient volume.
Thank you. And then I just noticed we had a couple more questions actually before we go further. The benefit of working with a group like Georgia High Tech prior to the post-payment audit is they're well educated and know this program inside and out. We also kind of share information with them, share our experiences with them. They can definitely kind of give you the do's and don'ts as far as filling out your MAPR application. That way, you know, it's better to ask them for help and get their guidance because they've probably seen it. They've already gone through it with another provider and can share the knowledge and experience with you now so that when you apply, maybe you don't make a mistake. And that way, it could be the difference between having a fail or comply as far as post-payment audit. There's also a question about for patient volume, if Medicaid was not the primary insurance and not the payer of the claim. So if I'm not sure if maybe one of y'all in this room's going through a current audit with us right now. For program year 2012 audits, that we're wrapping up currently for patient volume, if Medicaid was the primary, secondary, tertiary payer and paid an amount greater than 0 on the claim or the encounter, that can be included in your numerator. Going forward for all the program years 2013 and beyond, if Medicaid was the primary, secondary, or tertiary insurer, you can include that in your numerator. It doesn't matter if they paid or did not pay. So I hope that answers that question.
Yeah, and just to chime in on that, so the rule is that a patient can be considered a Medicaid as part of a Medicaid encounter as long as their patient is Medicaid eligible. So that's regardless of any other payer that may cover the stay or the service. As long as that patient was Medicaid eligible on that date of service, then that can be considered in your numerator.
We also have a question about should it be understood that post-payment audits are required or expected as opposed to being random? The answer to that question is yes, they are required. The state's required to have oversight of these payments because they're paying out this money. They do have to look at a certain amount of these payments in post-payment. Now, as far as how we, Myers and Stauffer, pick which audits we do, that is random, and it's based on a set of criteria that the state and Myers and Stauffer work with together as a team. And those details of that selection, we can't share them, but you can reach out to DCH and ask them if they'd be willing to share those details with you.
And I would just say, and this is an auditor talking, so as the auditor, I would just say be prepared to be audited, and if you're not, then you're just better off that you were prepared than to be caught off guard or unprepared and have to struggle on the post-payment side trying to come up with information that may be challenging to gather after the audit started and after time has gone by. So we just really encourage that even if you don't even get picked for an audit, you just don't know the chance of that. So best case scenario, to protect yourself, be prepared for an audit as you gather this documentation, making sure that what you submit in your application and in the MAPR system can be traced back to something in case you are selected for an audit.
Yeah, and just to point out, keep the documentation for 6 years. Just because we don't select you for an audit, that doesn't mean that if OIG were to come into the state of Georgia and pick audits that they wouldn't pick you for their review. So definitely keep your documentation. Always be ready, like Melanie said. The thing to point out that the continuation of the group proxy is once one provider selects a proxy, whether it's individual or group, it locks in all the other providers in that group. So if somebody goes through MAPR and picks individual first, but say you have maybe 5 other providers who want to use group, unfortunately that first provider who used individual has locked everybody else in to using individual. And it goes vice versa. If you select group first then everybody's locked into using group as well. And now for the don'ts. These are the things you don't want to do in order to have a negative experience with us. And when we mean negative, that doesn't mean we're going to be mean or anything like that. That just means we would recommend recoupment of the money, and nobody wants that. Again, don't ignore the notification letter. Just ignoring us and putting us off and acting like it's not there is the quickest way actually to get us to recommend recoupment to the state, unfortunately. Don't ignore the emails and phone messages. We do understand you're busy, so if it takes you a couple of days to get back to us, that's okay. When we mean don't ignore us, don't let it go 2-3 weeks and we don't hear from you. We've said this quite a few times. We're stressing it a lot. It's super important. Keep your documentation, whether it's access to your system, a backup of your system, or hard copies of the documentation for 6 years from the date you receive the incentive payment. And again, if you do change systems or you just get rid of the system, make sure you make a backup of those files so that if you were selected, you can document what you attested to in Mapper. And again, that's for 6 years. And then just to jump back to the security risk analysis, since it has been the big ticket item for us in meaningful use audits where it's caused the recoupment, just kind of touch base on it. I know we're kind of getting short on time, so we want to leave enough time for Q&A. Security risk analysis isn't actually anything new because of meaningful use. It was part of the HIPAA security rule in 1996. It's just that it was added as a requirement for meaningful use. So the good thing is probably a lot of you guys are already doing this, so it's not anything new, hopefully. So under the HIPAA security rule, you, the provider, should be conducting an accurate and thorough analysis of the potential risk and vulnerabilities to the confidentiality, integrity, and availability of EPHI. And actually, I think another question just came in. I'll just keep going and jump back to the questions. Once you have completed your security risk analysis, you are required to take additional reasonable and appropriate steps to reduce identified risks that are at medium or high levels. And as far as reasonable and appropriate, we don't gauge that in post-payment. We just ensure that you've done it, that you've looked at, you have risk, and that you've come up with a game plan on how to address those risks and minimize that risk. A security risk analysis is required when the certified technology is adopted in the first reporting year, and the risk analysis is required in each subsequent year when changes to your practice have occurred. So it's just every year you come in for a incentive payment, you should be conducting a security risk analysis. And you don't have to do a new one each year. You can update an old one, but it's important that it's done each year you get an incentive payment. Some important items with the security risk analysis. It's important that it's done during the proper time period. You should have a completed SRA by the date you attest, by the date you get your incentive payment. You shouldn't just look at your EHR system. It should encompass physical safeguards like the doors, the windows. It should encompass administrative safeguards, technical safeguards, as well as conducting an asset inventory. And the asset inventory should identify where all EPHI is stored, received, maintained, or transmitted. This would include things like a printer, a fax machine, your laptops, your computers, iPads if you use them, things of that nature. Also, components of the SRA, you should identify threats and vulnerabilities. You should identify the likelihood that a threat could occur, whether it's high, medium, low. You also need to identify the impact of that threat. You should have a final report. And like I mentioned earlier, there should also be an action plan for the medium and high risk items to show how you'll fix those or address those items. The thing with the SRA is there's no one set way to do it. There's a lot of templates out there. There's a lot of companies that offer guidance on this. It's just important that you hit all these kind of items we've listed out in bullet form. Again, Georgia High Tech is a good source to help you should you have any questions or doubts whether your SRA is sufficient or not. They can definitely help you before you get paid the incentive payment, helping you make sure your SRA is going to be solid and meet the requirements in post-payment. Again, for probably like the 20th time, how long should you keep your documentation? You should keep all your supporting documentation for meaningful use or AIU for 6 years after the date of attestation. And that's the minimum. It doesn't mean at the 6-year mark, just throw it out. You can keep it longer if you would like. Here is our contact information. Should any of you guys need it. As I said earlier, we're really not the ones you want to speak to before you get paid. We're the ones you'll deal with after you get paid. So definitely reach out to HPE, Georgia High Tech, or DCH should you have prepayment questions. And I'm sure that's a lot to digest. Hopefully, don't worry. Everybody stay calm. It'll be okay. This program can be very difficult with all the rules, but there's a lot of resources in this group that can help you get through this process and get through it successfully. And now, if there's any questions or answers, or questions.
Thank you, Jeff and Melanie. And we are now open for Q&A, but I would also like to point out, for those of you, many of you had some wonderful questions, and we encourage you to contact the Georgia High Tech Support Center. The telephone number and the email address can be found in the tech support chat pod. And we're now open for Q&A, so please feel free to type your questions in the presenter Q&A pod. So we have one question here. What are the benefits of working with a group like Georgia High Tech prior to, during, and after an audit?
Well, we kind of went over that a little earlier, but again, they have the experience, they have knowledge. Doing outreach myself with the boot camps with DCH, I've met some of the people from Georgia High Tech. They definitely have experience, they have the knowledge. If you're going through it, more than likely they've probably already seen it and know how to help you overcome a hurdle or definitely get you an answer to any question you may have. It's better to ask than have doubt and proceed with your application with doubt. There's no reason not to reach out to them and get a solid answer so you know that you're on solid footing when you get your application and receive the incentive payment.
And I would just chime in that they work well with the HPE, which is the contacts that process the MAPR applications, and they also are very familiar with the staff at DCH. So Georgia High Tech can be the stepping stone that bridges the gap from having not knowing where to start to being able to direct you to the appropriate resources depending on whatever the question or issue is that you have.
Thank you for that very thorough answer. So our next question, and it's a bit of a scenario in the midst of that, I have a new provider this year who has more than 30% Medicaid volume in the first 90 days of 2016. May we report a 2016 AIU, these providers using a 2016 PVC?
So for a program year 2016, you would be able to use that time period because part of the rules allow you to pick, you have an option. You have the option to pick a 90-day period in the prior calendar year. So for program year 2016, that would be a 90-day period within calendar year 2015. But the other option is that you can pick more recent data as long as it's prior to the date of 12 months, within the 12 months prior to your date of attestation. So if you're attesting now in the middle of 2016, you could still use a time period in early of 2016 or all the way up to your date of attestation. So yes, you would be able to use a 90-day period in 2016.
And again, we are open for questions for Jeff and Melanie. Feel free to type your questions. And if Jeff and Melanie, if you have any additional thoughts that you would like to share during this time, we have about 4 more minutes until our webinar concludes. We encourage you to share those.
I'll just chime in as we wait for any other questions to roll in that I think we're probably some of the nicest auditors you'll meet. I know that's hard to hear from us, but we really do want to work with providers. We're not out to get you. We're not like typical auditors that you may have already had to work with. We're really trying to be there to make sure you meet the rules of the program and make sure you keep the incentive payment that you've already received. So we're willing to work with you within the realm of what the rules allow. So please don't feel stressed out if you get that initial phone call or that notification letter. That don't stress out. We'll work with you. We'll make sure that we can do everything we can to help you get through the audit process.
Do have an additional question. Johnny would like to know, where can one find all the rules in one place, a simplified version of all the rules?
Well, on the DCH website, we do have our tip sheet up there, which is a one-page tip sheet that will summarize a lot of what we just went over. And I'm sure probably Georgia High Tech has some resources available to you as well that would summarize these rules in a lot cleaner, more straightforward fashion. But on the website, though, for DCH is the tip sheet for post-payment audit.
Okay, we have a thought from Judy. She says, thank you first. When I run the Medicaid population encounters, our EHR is set up to count claims only. Should I also run a total of all appointments for the provider?
Yeah, the report should definitely include all the appointments. Sometimes some systems won't create a claim for every visit maybe that provider has, so maybe the appointment listing would catch some of those per se. So it's definitely better to generate the report to catch all the patients who came in and saw the provider through that 90-day eligibility period, not just for the ones where a claim was created.
And I would chime in too that if it's an appointment listing, you might want to be aware if you had anybody that was just a walk-in that maybe didn't have an appointment, that you need to include those walk-ins in your calculation as well. And then also if you have anybody on the appointment listing that for whatever reason was a no-show, you need to make sure you exclude the no-shows. So be mindful when you're using an appointment listing that you're making sure to include people that didn't have an appointment and then exclude people that were no-shows.
Well, thank you. We have reached the conclusion of today's webinar, and as we've noted at the beginning, the webinar presentation and recording will be made available. It will be housed on the website www.gahightech.org. Jeff, Melanie, we thank you for a very informative and educational presentation. And on behalf of Carmen Hughes, Executive Director, and Dr. Dominic Mack, Executive Medical Director, and the entire Georgia High Tech team, we thank you for your presentation, Jeff and Melanie, and we thank each of you for attending.
Thank you.